Montreal, and it's my pleasure to welcome everyone this afternoon to the second part of JNF's special climate change web series. So 2 weeks ago, we were joined by Laura Faye Tenenbaum, a renowned former NASA scientist, who gave us the big picture of where the world is heading if we as a society are not prepared to take immediate corrective action on the climate front. Today, we're very privileged to be joined by Dr. David Fisman from Toronto and Dr. Jacob Moran-Gilad from Israel, who are two of the world's top experts in their fields to discuss how climate change may impact the emergence of possible future pandemics. We chose this topic because we believe that if COVID-19 had taught us anything, it's that the same science that predicted the current pandemic also tells us that we may unfortunately also be in store for future ones. And the severity of these future pandemics will certainly be affected by how we decide to manage the climate change crisis. At this time, I'd like to introduce you to our wonderful MC, who mentioned his name already, Phil Frey, who is also JNF's program director in Montreal. At any time, please feel free to type in your questions in the Zoom chat. Phil will do his best to address as many questions as possible when he gets to the Q&A session. So before I give the floor to the two doctors, let me briefly introduce them. Dr. David Fisman is a professor of epidemiology at the University of Toronto's Dalla Lana School of Public Health and an infectious disease at the Michael Garron Hospital. He received the GalaxoSmithKline Elion Young Investigator Award for his work on mathematical modeling of sexual transmitted infections, and a Golden Apple Teaching Award from the Drexel University School of Public Health. Dr. Fisman's work on modeling the current pandemic has appeared on CBC, in the Globe and Mail, and in the New York Times. Professor Jacob Moran-Gilad is a medical doctor as well as the chair of Israel's National Advisory Committee on Microbiology and a member of the National Epidemic Management Team and has been actively involved in managing the COVID-19 pandemic. He is the project leader of the Microbiology, Advanced Genomics, and Infection Control Application Laboratory called Magical Group at the Ben-Gurion University of the Negev and consultant microbiologist at the Soroka University Medical Center in Be'er Sheva, and director of clinical microbiology at the Hadassah Medical Center, Jerusalem, Israel. So first of all, welcome to both of you, and thank you for being here today. Dr. Fisman, you're up first. Thank you.
Thank you, and thank you so much to JNF for the privilege of speaking in this kind of company with Dr. Moran-Gilad. I know Stephen Hoffman's been another speaker in this series. And thank you for prioritizing climate change as an issue, even in the face of the pandemic, which I think right now is holding on to a lot of our attention. It's important to remember that there are lots of linkages between the current pandemic and the situation with climate change. And I want to applaud you for having the insight to link the two together. So let me start. I'm going to try to keep this very short. I have a clock right next to me to keep me on time. I have 10 minutes. And so here we go. Okay. So what are the linkages? And we don't have a lot of time. We're going to keep this short because we want to keep this maximally interactive. But what I would say to you is climate change and emerging infectious diseases overlap a lot. They have shared drivers for both problems. They're both wicked problems. They have shared drivers. Human population growth is a big one. We're pushing 9 billion over the next couple of decades on Earth. Whether that's exceeding Earth's carrying capacity remains to be seen. They're both driven by environmental degradation. They both have strong links to how we produce our food to feed 8-9 billion humans. So they have some shared drivers in terms of economic activity. They also have some shared patterns where what you see is local activities and local phenomena have global impacts. So we can act in our own self-interest by having a global view. and ideas that, I'm going to look after my own backyard and not worry about the other people's backyards doesn't work very well in this very connected world with either of these problems, because they both become everyone's problem very fast. Both are characterized by lagged effects, which I'll try to demonstrate. Both are characterized by positive feedback loops, whether you're talking about an epidemic or whether you're talking about carbon in the atmosphere. The more you have, the more you get. And both are characterized by exponential change, exponential increase, which hopefully we've learned from our learning in real time with Florida and Texas exploding. Exponential change is a terrifying thing to witness. And then lastly, I think there are direct links where climate change is probably an important factor that is contributing directly to emergence of new infectious disease. This EID here is not Eid Mubarak, it's emerging infectious diseases. So we have direct linkages via speeded up evolution. A lot of biological processes or biochemical processes happen faster at higher temperatures. And we also have the issue of expanded range for vectors. So very, very quickly, whoops, move to the next slide. Here's what I mean by the importance of lags and the importance of acting before you have a problem. On the left-hand panel, what we have is a figure that my colleague Ashley Chute and I published a couple weeks ago in Annals of Internal Medicine, looking at what happened in Ontario with a lockdown that happened very early on. This dashed line here is ICU capacity. This is COVID. And what we did is we locked down in Ontario before disease had exploded, before we knew our ICUs are full. Sometimes when we have models, when we understand systems, we can understand how important early action can be. Because if we wait until we hit a crisis, what you see here is if you lock down with COVID when your ICUs are full, that doesn't stop your ICUs from filling, and it doesn't undo the last 3 weeks of transmissions, which are still coming at you. So our assertion is that this is what we avoided with an early lockdown in Ontario. We can look at sort of exponential growth processes over time. Over here, this is an old IPCC graph of what's happening to global temperature. And it's sort of the same idea that what you want to do is shut down the carbon increase way early, because if you shut it down late, this whole process is still in the hopper. It's still in the pipeline, still coming at you. So I hope that's not too strained an analogy. But I think there's a direct, they're different time scales, but there's a direct analog in terms of the importance of early action before we're in the soup. Because if we wait until we're in the soup, it's very hard to get out of the soup, and it comes at great cost. So I want to very briefly, because I don't think most folks, this is sort of, Jacob and I live in this world, and I think this is probably self-evident old news to us, but I don't think it's old news to folks who don't live in our world, which is where do new emerging infectious diseases, EIDs, come from? Almost all from human interaction with animals and environment. So this is an old paper by a guy named Peter Daszak, who runs something called the EcoHealth Alliance, looking at zoonotic diseases from wildlife. Those are diseases that jump from animals to humans in terms of where the new diseases are coming from. Zoonotic diseases, animals to humans from domestic animals. Antibiotic resistant organisms, which also have a linkage to animals in food production, because we feed animals antibiotics to increase yields, make it faster to produce things like meat and crops. And then we have vector-borne diseases, some of which are also related to animals and destruction of habitat. And you can see all the way along, we've sort of got this rich belt around the center of the planet where there's a lot of economic activity, a lot of habitat destruction, and we seem to really be increasing our vulnerability to emerging infectious diseases by economic activity in this sort of peri-equatorial belt. And most of that involves habitat destruction and how we interact with animals. Well, when I teach students about emerging infectious diseases, I talk about it as kind of growing a garden. It's, maybe the garden from hell, but you're still growing a garden. So how do diseases emerge and spread? It's just like growing a garden in your backyard. You need two things. You need a seed, which is the new pathogen, new opportunity for human infection. For example, if humans go into rainforest where they haven't been before, or humans introduce species into what was formerly rainforest for food production, you can have bugs, viruses, and bacteria jump to new species that they never had the chance to infect before, and from there to humans. But you also need soil that allows exponential growth. each old case to make more than one new case before it gets better. And that's how we get into pandemics. So the soil is changing, and the soil is changing because of climate change, at least in part. We don't have time for a deep dive into this, but something that I've always regarded as interesting and mysterious is since 2010, we've witnessed a lot of insect-borne infectious diseases emerge in the Americas, which were never there before. West Nile emerged around 2000, famously in New York, was never there before. But what's interesting is folks have attributed that to trade and travel, but trade and travel has always been there. And if you look, for example, at the slave trade, where you had tremendously close linkages established between Africa, between sub-Saharan Africa and South America, we know that a bunch of infectious diseases came with their insect vectors during the slave trade. Yellow fever, dengue, falciparum, malaria, all crossed the ocean with mosquitoes. There are a bunch of other diseases that probably crossed too, but couldn't take off. So when we look at things like Zika, like chikungunya, like West Nile, we have to ask ourselves, what's changing? And I don't need to dive into that. But what we can see is that emerging infections are all about tipping points. And for vector-borne diseases, mosquitoes particularly are very sensitive in terms of their biting rate to temperature. And reproduction numbers for mosquito-borne diseases thus increase to the power of biting rate squared. So as you warm up these systems and you start with a reproduction number below 1, where emerging infections can't take off, this is something like Zika, probably down here on the orange line, sorry, on the blue line, which had a baseline reproduction number just under 1. If you just increase that biting rate slightly by increasing temperature, all of a sudden we're into epidemics and pandemics. The last thing I just want to touch on, and this is some brilliant work from one of the neat things about, I'm going to take the liberty of calling it my friendship with Jacob, is that we keep intersecting in all kinds of weird and interesting ways. And Jacob runs now something called the ECMID meeting, which is the European Microbiology and Clinical ID meeting. And so I've had the pleasure of getting to know him a bit through that process. But we also work together via some other intermediate people on antibiotic resistance. And this is some brilliant work by a former student, now faculty at University of Ottawa, named Derek McFadden, looking at what happens to antibiotic resistance with ambient temperature outside the hospital, and finding that you can literally make heat maps. If you normalize these resistance scores for, there's a lot of scatter, he's trying to normalize based on place-to-place variation. Higher temperatures really do seem to be an important driver of antibiotic resistance in what we call gram-negative bugs, which are poop bugs. Those are bugs that are out there in the environment and have lots of opportunities to exchange genetic material with other bugs, and also lots of opportunities to mutate and be selected out in the presence of probably low environmental concentrations of antibiotics. And temperature seems to be a driver of that process. So for a bunch of the things that we're interested in and that we regard as threats to human health, turning the dial up on temperature makes all of this worse, and is as big of a problem as we see with climate change in terms of COVID, in terms of if you successfully start to control things, people say, oh, well, we did all this stuff and nothing happened. So our challenge as scientists is to show people what the alternative universe is and to explain it in a way that they can understand what will happen in the face of inaction. And again, I think there are a lot of parallels between climate and emerging infections. So with that, I hope I've stuck to my 10 minutes, and I will stop now and turn it over to Jacob.
Thank you so much, Dr. Fisman. For those of you who have any questions for Dr. Fisman, hold on to them for just a few more moments. Send them through on the chat. We're going to address all of our questions after Dr. Moran speaks. And with that being said, Dr. Moran-Gilad, the floor is now yours.
Thank you very much, Phil, and good afternoon or good evening, depending on where you are. So it's a real pleasure to take part in this event, and thank you for the very kind introduction, and also David for your very nice talk. So I will try to share my screen. Okay, so I'll try to pick up where David stopped and try to focus a bit more on COVID-19 and what lessons can we learn for the next pandemic. So we're all now experts in flattening curves, I suspect. 4 months ago, I bet that the majority of the population never heard about epidemic curves, and now we're all experts, which is also a sign to how we very efficiently disseminate information during this incident. And I think we're still in the process of trying to learn how this virus and this disease behaves. But what is clear is the fact that we're now very much concentrating on the containment of COVID-19 and the mitigation of the dissemination of the virus. But we're not talking so much about prevention because we're in the midst of a significant incident. But of course, as we always say, an ounce of prevention worth a pound of cure. So obviously, it's better to put our efforts in trying to prevent disease from happening in the first place. And of course, this has to do with the natural occurrence of pathogens and their emergence with all the interfaces that David already alluded to. So we're seeing an explosive event. So this rather dense illustration just from yesterday shows the superimposed curves in different parts of the world. And you don't have to be an epidemiologist to see that we all, in almost all countries, we start with a very steep increase in cases. And now that the curve has flattened in most countries. This does not mean that COVID is gone. It is just under certain control. And of course, this varies between the localities. And if we look at the mortality, then we also see disparities in mortality rates. But what is important to highlight, and even with this varying mortality, the mortality rates of COVID-19 have been around just a few percents, maybe less than 1% in different settings. And I'm not trying to underestimate the impact of the disease because even 1% mortality when millions of cases are involved, of course, leads to a significant public health impact. But my point is that this is not the pandemic that we were preparing for. So as professionals in the field of infectious diseases, for many years now, we are discussing what we call disease X. So that mysterious yet to be identified pathogen, which will be highly transmissible between person to person and also result in a very high mortality rate. That means 10, 15, maybe 30%. And such a pandemic is, of course, a significant risk to the world's population. And this is not what we are coping with at the moment. We're coping with a highly transmissible disease, but a mortality rate which does not exceed the expectations for a respiratory virus. And that means that despite the chaos that we're experiencing at the moment, we can still refer maybe cautiously to that incident as a drill to the real thing. And the real thing could happen in 1 year, 10 years, 100 years, I don't know. But definitely we need to learn many lessons from COVID-19. So this, what we call phylogenetic tree, juxtaposes different genetic sequences of viruses. These are all coronaviruses. In red, you see the SARS coronavirus 2, which is the cause of COVID-19. And you see that it's a very close neighbor of SARS, the very same SARS that we were experiencing almost 2 decades ago, that also emerged in Southeast Asia and also disseminated to Canada and other countries in the world. And it's not that far off from many other coronaviruses that we know, including coronaviruses which are causing common respiratory infections every winter season. And these viruses are just an example, because we have many dozen other coronaviruses which are just out there in different ecological niches. Bats are notorious for being reservoirs of coronaviruses, but many other animals. And of course, climate change has a significant role in creating the right environment and the right conditions for those viruses to do what we call the species jump. So to adopt and start to infect humans, which are accidental hosts for those viruses. And so we're still learning how this disease behaves, and there are many models. David is an expert in those models, but this is just to say that we're still not sure how many people are asymptomatic and how many are symptomatic. And we're still learning and trying to predict the severity of disease and how to treat it and how to prevent it with various measures. So the dynamics of the disease are still not clear. And also the outcome of the event. This is just one model out of many. And it shows that we are very far off from achieving herd immunity, which means that without a vaccine, we are destined to see coronavirus circulating with us for the next couple of years, and maybe further than that. So what should we learn from coronavirus and other emerging infections on how to prepare for the next pandemic? So my first point is pathogen discovery. And pathogen discovery means that we need to perform a lot of scientific research to understand better the viruses within animal hosts. And of course, this requires quite a lot of investment in resource. And it's, the outcomes of that sort of research are not immediate. And I will cautiously say that if we were investing maybe $100 million in that scientific avenue over the last decade, we could have prevented an economical loss of 10 trillions just in the last couple of months. And I think this is a major point for us. And then we need to scan the horizon, because those ecological niches constantly change, and we need to identify subtle signs that could predict that different viruses could emerge and infect humans. And we need to perform studies in order to explore whether human exposure had already taken place, and not to wait, for the first cases to act as a sentinel for the new emergence of a disease. And of course, we need to characterize those pathogens and perhaps start thinking on putting in place diagnostics and therapeutics and vaccines for the disease agents that we are not yet sure that will come our way. And we need to have in place early warning systems and sentinel surveillance systems, which could create alert. And that also means that we need to track what happens in nature, and to do that in a holistic fashion. So to look at human health, environmental health, animal health, because everything ties together. So we need to work across sectors. And with those R&D efforts, we may be able to generate planning and preparedness for the next pandemic. And I will finish off with some interesting data that we just generated through a scientific study. So we used big data analytics and what we call NLP, natural language processing, or text analysis, and we analyzed about 50 million scientific citations from the last 2 decades. And what you see here is a comparison of emerging viruses like SARS and MERS here at the bottom, as opposing to other viruses which we all know, like influenza and hepatitis and HIV. And what you can see is that scientific publications tend to peak after we witness those incidents, like SARS in the early 2000 and MERS later on. But then the scientific publications subside. And that means that our interests as scientific community and also the interest of funding agencies is also depending on disease dynamics. And on the right-hand side, you can also see the correlate of that in scientific publications in high-quality journals. So high-quality journals tend to be very receptive of papers 1 or 2 years after the epidemics have taken place, and then they lose interest. And my point being that we need to create a different legacy for COVID-19, and hopefully within 1 or 2 years we're able to contain this pandemic, but we need to continue investing in that, because otherwise the next pandemic will find us unprepared. So thank you very much for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Moran-Gilad. We do have quite a few questions that have come in already for both of you. For anyone else who do have questions, feel free to type them in. We're going to try to get to as many as possible. Dr. Moran-Gilad, you actually just recently touched on future pandemics. There's been a lot of recent talk in the media about a new H1N1 taking place in Asia. Do you have anything to comment on this? Ways we can possibly prevent this from becoming the next COVID-19 where the world shuts down?
Yeah, so I mean, that virus caught media attention, but there are probably many other viruses that did not catch media attention and are no less important. H1N1, as you know, is also a descendant of a pandemic that just occurred a decade ago. It was not that lethal, but H1N1 still is still with us. We witness every winter millions of cases of H1N1 and also fatal cases, especially in the more susceptible population. And that is despite having a vaccine against influenza, which of course is not 100% effective. But what I do take from that is that maybe the media and public opinion are now more sensitive about newly emerging viruses, and that is a good sign, but we need also not to panic because there are many viruses out there and we still have a lot of work to do with COVID-19.
A follow-up question to that also from Dan. You talked about the correlation between animals, human health and everything. Would you suggest maybe, do people stop eating fish and stop eating meat to prevent some of these future pandemics, or is it more tackling the climate crisis that can potentially help slow down some of these pandemics or prevent them altogether?
Okay, that's an interesting question. I'm sure that also David will have some thoughts about this.
David, join the party. Don't be shy.
Maybe I'll start.
Jacob, finish.
I'll start off by saying that first of all, animal food source is also it could result in foodborne infections, and this is one big issue that we need to take into consideration, because the public health burden of foodborne infections is significant, and we tend to sometimes to overlook that. And of course, animal husbandry in general is associated with an increased interface between humans and animals. And for that reason, pathogens that are emerging and disseminated within animal husbandries could, at the end, result in emerging infections. But a significant number of emerging viruses actually emerge in the wildlife. And another angle is the fact that animal husbandry is also associated with, of course, a significant impact on climate and on planetary health. And so we have now far more chickens and cows than humans. So this is a significant issue, and I don't think that we need to be, very categorical about things. Stop eating meat, but definitely things needs to be better regulated. We need better surveillance systems, and we need not exaggerate in anything that we do.
I mean, I would just add, I'm sitting next to a young lady who is scandalized that her chicken soup supply may dry up. So I just want to reassure her that we are not advocating that. But the way we produce our food, we do have a lot of mouths to feed on the planet, and I would just reiterate what Jacob says. And it was said, intensive factory farming has been a driver of some really important challenges in infectious diseases, including verotoxigenic E. coli, including antibiotic resistance. We have intensive factory farming happening in former wilderness areas. This is the mechanism for emergence of Nipah virus back about 15 years ago, with pig farming in formerly pristine rainforest. And then the other aspect to food production and a lot of hungry mouths is that bushmeat becomes a protein source of last resort or not necessarily last resort, becomes an important protein source for starving people. So the consumption of wildlife and the interaction between humans and animals was important in the 2015 Ebola emergence. It may or may not have been important in the current COVID pandemic. It probably was important in the emergence of SARS. There's an animal tie-in and a food production tie-in to MERS coronavirus. Influenza itself is a human, pig, and bird disease. So we've got a HIV itself, is a primate disease that may have crossed over to humans via something to do with bushmeat consumption. So I agree with Jacob. None of these are necessarily extreme solutions. Incremental solutions are good for processes where you have tipping points, right? That's the important thing about climate change and emerging infectious diseases. If you moderate things, it can be enough. We're seeing that right now with social distancing and COVID. We've, in Ontario, we haven't been the superstars of Canada in terms of COVID control, but we've got a reproduction number that's down around 1 by canceling the most extreme interactions, sort of the big crowding events, the concerts and the big sporting events and things like that. So you don't need to shut things down totally. You just need to understand systems so you can predict and control. And eating animals is a source of vulnerability for us. And we need to understand those systems so that we can predict them, so that we can control them, so that we can reduce our vulnerability.
Thank you so much. You just touched on, not shutting everything down, but being responsible as we slowly go back to normal or the new normal. What message would you have to those who think to themselves, well, the parks are open, the hockey rinks are open, the bars are open, let's just go on out there. And I don't need a mask. I'm healthy. I'm 32 years old. I'm a healthy young man. What would you say to those people?
I mean, do you want that one, or I can? I have some pretty strong feelings about that.
I'd love to hear both of your inputs on that one.
So I think the important thing for us in Canada, and I think Israel is on this list, although I think they've been having some setbacks recently, would actually be very interesting to hear Jacob talk about how the Israelis have responded to a recent surge, because I think we've been a few steps behind Israel all the way along in terms of control. And they're dealing with stuff now that I think is in our future. So I think it would be very instructive to learn from Israel. there are a number of countries that have done better on this than Canada. There's a rather large country to the south of us that's done considerably worse. But if you look at the countries that have done better, the Japanese nailed the messaging early on, the 3 C's, closed, close, and crowded. If you can avoid closed, close, and crowded, this thing goes on to a slow burn. And these super spreader events, it's a weird disease because you have a lot of dead ends. We see this on airplanes all the time. We see people, I think there was just a flight documented where you had 16 people with COVID on the flight and 1 secondary infection. That's a reproduction number of 1 over 16. And then we have super spreader events. I keep coming back to the Daegu, Korea event where you have 1 person infect 40 secondary cases by going to a buffet and to church. So it's a weird disease and it messes us up because it's not infectious, but it's also highly infectious. But what the Japanese have found is the avoid closed, avoid close, and avoid crowded seems to get you most of the way there. And then we can't avoid closed, close, and crowded for everything. I think schools are the one big gathering that it's really hard from an economic and social point of view to close. So I think you do your best, and masks help you when you can't avoid the 3 C's. And you test a lot. And the Israelis have done a tremendous job with that in terms of scaling up testing, because it's an insidious thing, and it's really hard to see if you don't have good test capacity. I think we're there now in Canada. It took us a while to get there, but I'll leave it at that and turn it. I think I know the bars are opening back, and I think that's, I think avoiding the dumb stuff is good, and I think opening the bars is a priority when you're still trying to figure out schools. In the Fisman worldview, opening the bars before you figured out the schools is a dumb thing, but I realize that's not everyone's view.
Dr. Moran-Gilad, anything to add?
Yeah, so I also have mixed feelings. I think that in Israel we were witnessing in the early phases, we had a later introduction of COVID-19, mainly because we were amongst the first to reduce international travel and incoming flights, and that delayed the dissemination of COVID-19 by a few weeks. And I think we also managed to do well with the lockdowns. I mean, we ended up having a lockdown. In my eyes, the release was too hasty, and I would prefer to have a slightly more gradual release. And now we're seeing an exacerbation in the epidemic curve, and I think that reflects a composition of few things. First of all, and this also corresponds with what you were saying, Phil. So it's people's attitude, their risk perception, and I think that we're seeing a different behavior amongst the elderly at that point in time. They're much more careful, and I think that we did a good job in conveying the message to that age group that they are in high risk. And for that reason, we're seeing a completely different age distribution of cases now, as opposing to what we were seeing in end of March and early April. But on the other hand, we need to remember that statistically, even young and fit individuals could develop severe infection. The risk for that is much lower, but when you have a very high number of infections, those statistical outliers will occur. Then we need to remember that in the Western world, obesity, diabetes, hypertension is becoming more and more common, and maybe a third of the young to middle-aged population have at least one risk factor for severe infection. And that means that also in that age group, we will be seeing severe infections. So my point being is that the risk communication to the younger age groups is highly important. And I think we need to do a better job in that respect. With regards to masks, I mean, we're still lacking scientific evidence about the efficacy of using masks outside healthcare settings. But I very much agree with what David was saying. The single most intervention, if you like, is to keep those 2 meters between individuals. I mean, that I think is the single most important intervention. And if we're failing that, so if we breach the 2 meter distance between individuals, then I think the masks have an important role, and especially because we have asymptomatic individuals who are infectious. So, as I said, a mixed feeling, but I don't think we can just ditch the masks. Sorry.
Dr. Fisman, you pointed out earlier that we not too long ago had Dr. Stephen Hoffman here discussing Canada's response to COVID-19, which brings us to a question from Aaron. With the COVID-19 vaccination at the forefront in the media and on our minds, how do we avoid falling behind in the worldwide vaccine coverage and undoing decades of progress there? And to follow up on that, how would this affect the emergence of new pandemics?
Sorry, I just want to make sure I understand the question. How do we avoid falling behind in what in traditional vaccine programs?
Exactly. So I think what she's trying to say is, you know, everyone's focus right now is let's find a cure for COVID-19, but what about H1N1? What about cancer? What about the the other diseases out there?
No, I mean, absolutely. I've been a big advocate for pretty aggressive health testing in the healthcare setting, because I think there are a lot of essential services that need to go on, but a lot of those focus on more vulnerable folks, where the last thing you want is an outbreak in an oncology center. For example, immune compromise seems to be an important risk factor for mortality if you get COVID. So no, I think it's very important to try to maintain other health services. You know, what I think you want to avoid a couple of things. One is what was interesting in Ontario is the extent to which elective surgery was a driver of ICU occupancy, which is obvious in retrospect. You know, they stopped doing hip replacements and they stopped doing valve replacements. You know, if 1 in 100 of those folks winds up in an ICU and you're doing high volumes of surgery, that actually becomes a lot of ICU occupancy. So that's one reason where I think during the initial wave, it was important to suspend elective procedures. And the other thing is healthcare, you know, is healthcare an environment with enhanced vulnerability? And this is a very controversial issue in Ontario. Healthcare workers seem to be infected at a rate about 20 times higher than the general population. And there's 2 schools of thought on that. One is that they get tested a lot more because they're prioritized. And the other school of thought is, yeah, there's actually transmission going on in hospitals and we don't always recognize it. I think it's probably a combination of the 2. And there's been some interesting work from the Netherlands trying to look at that in their hospitals, looking at using the sorts of tools that people like Jacob, people who are much smarter than me like Jacob use, where they look at it, you know, the phylogeny of viruses, the family tree, and try and figure out which virus is related to which virus. And in the Netherlands work, it really looks like the healthcare workers are getting it in the community. But that doesn't mean they can't transmit it to patients. And we also know that's happened, for example, in Toronto. So I mean, again, I think I'm a bit of an outlier in terms of some of my colleagues. I think the Newfoundlanders say you hunt the virus, and I totally agree with that. I think it's sneaky, and you test until, as our colleague Aisha Verrill says in New Zealand, you're testing people for stuffy noses. You know, you're getting to a ridiculous point where people say, come on, you're testing too much. I think once people are saying, come on, you're testing too much, you probably got it about right. In terms of, just to keep it short, in terms of, sure, pediatric vaccine program is very important. We don't want those to resurge. That's been an issue with a lot of diseases. You saw that in Africa after Ebola came measles, because the Ebola crisis killed the measles vaccine program. It's a very real concern. I think the other really important acid test, I would say, is we've talked already about other flu strains. You know, in infectious disease epidemiology control, vaccine development, we've been talking about a universal influenza vaccine for a long time. There are literally hundreds of influenza strains, but they're all influenza viruses and they have commonalities. So that's sort of the holy grail of flu research, is could you get one vaccine that knocks out every flu virus? If we could do that, we've ticked that problem off, and we know there's ongoing emergence of flu viruses. This is an H1N1, but we've had an H7N9 a couple of years ago. H5N1 is always there. You know, H3N2 can recombine. So you know, flu is an endless challenge. So what I'd like to see is, you know, we got to get through this, and I'm pretty optimistic about prospects for vaccine development. I think there are actually, and maybe we can talk more about that, but I think there are already vaccine candidates that look amazingly promising. But if and when we get through this in 2 years, 6 months, I don't know, 3 years, whatever it is, my acid test in terms of what have we learned is, do we see, you know, Gates Foundation pushing for the universal flu vaccine Manhattan Project? Because it's an ongoing vulnerability for us. The WHO also has a priority list of about 10 pathogens, most of which nobody's ever going to have heard of, which can do this too. So SARS coronaviruses are on the list, MERS coronaviruses, you have Nipah virus, which we've mentioned, Crimean Congo hemorrhagic fever, which nobody's heard of, Rift Valley fever, which nobody's heard of, Marburg virus, which nobody's heard of. But you know, these are things that are on that list as pathogens that can do exactly this thing. And what we're learning with vaccine development is it's very hard to build and then land the airplane while you're flying it. So we really need to focus on developing these tools, at least having a vaccine on the shelf that's been through trials before we get hit. So that to me is the big acid test. You know, how much can we learn as humans? Do we learn our lesson and actually do some of that vaccine development proactively? And I guess we'll see. I'm curious. I'm pretty skeptical, but it would be nice if that happened.
May I add to that? I mean, first of all, I completely agree with respect to the vaccines. And in addition to a universal influenza vaccine, there is also perhaps the possibility of developing what we call a pre-pandemic vaccine. So a vaccine that could be, in the face of pandemic, be modified and fine-tuned to a specific pathogen. But I want to go back to the business of routine immunization, which I think is an extremely important point, because there is a lot of disruption of standard healthcare during COVID-19. And it's not only about the susceptible populations like the immune compromised and so forth, but we have regular services which are disrupted. And that means that chronic diseases are not treated as efficiently as they should be. People are afraid of seeking healthcare. And we had in Israel cases where people died because of myocardial infarction or stroke, because they were afraid of going to the emergency room, fearing of contracting COVID-19. So that means that we will be seeing also excess mortality with respect to non-communicable diseases, not to mention the fact that we don't have data yet, but I'm sure that there are so many aspects of preventive medicine which have been neglected, mammographies, colonoscopies, whatever. And to the extent that in 2 years from now, we could be seeing a peak of mortality from preventable disease that has not been screened. So, and maybe to add to that, the fact that the economical crisis that is around the corner could also impact health disparities. So I think that over and above the immediate health outcomes that we see related directly to COVID-19, we are going to see at least the number, if not a greater number, of mortality cases due to indirect damages of the pandemic. And this is a death toll that is much more difficult to appreciate because you know, we don't have maybe the best tools in order to attribute all those cases to the pandemic. But it's really an emerging field of study in public health, and we should be mindful of that.
Thank you. We're coming down to the wire, so this may potentially be our last question. Dr. Fisman, like you said, whether it's 2 weeks, 2 months, a year, 2 years, 3 years, fingers crossed, a vaccine is coming, and God willing, this will become something that is preventable, and you'll get sick, you'll get vaccinated, there'll be something, you move on with life. The climate crisis, that is still going on. And our question coming in from David is, how will climate action particularly provide for better human health? And at this stage where we are in terms of climate crisis, how does one coexist with the other?
Yeah, I think that's a great question. There's, oh gosh, I'm blanking on the name. There's an Australian physicians climate group that has talked about the concept of a health dividend, that mitigation of climate change and promotion of human health actually goes somewhat hand in hand. And the elephant in the room on climate, I think, is population growth, which I don't have any easy prescription for. The more humans there are, the more carbon we're going to emit whatever else we do. But let's leave that aside. That's a problem that's beyond my sort of tiny brain. But in terms of thinking about getting people more active, getting folks on bikes more, I mean, Montreal's been magnificent for this. You're both reducing emissions, and you're also reducing some of the sequelae of inactivity by building neighborhoods in a different way where they're denser, less sprawl. You're encouraging people to have a more healthy walking lifestyle. By encouraging sort of local production of healthy foods, you may be moving away from the high carbon footprint associated with food that comes from 5,000 miles away. So there's this idea that there's potentially a health dividend just from those mitigation activities. And I'm probably not doing that justice. I will say, Jacob's a clinician as well. I mean, I will say that one of the things that drives me most crazy when I do ID service is diabetic foot ulcers. And I always feel like by the time I'm seeing a diabetic foot ulcer as an infectious disease clinician, it's 10 years too late, right? Because that's happened now. And what we should have been doing upstream is helping that person with glucose tolerance by encouraging a more active lifestyle and helping them make healthier choices in terms of diet. Because by the time we're into sort of doing the salami stuff on their heel ulcer or what have you, it's a very bad problem. And I think a lot of our focus needs to be more upstream. We can also look at other health dividends associated with reduced emissions. We're getting into more and more heat emergencies and extreme weather events, and those actually kill people. I mean, when you're at a point on the US East Coast where you have 100-year storms every 3 years, it's probably time to stop calling them 100-year storms. Those are economically devastating events. Those are devastating from the point of view of health. We've seen wildfire events, for example, in Australia over the last couple of years that have been very damaging to both health and the economy. So, at some point we need to start thinking about acting in our own self-interest in terms of preventing what's coming down the pike. Because we're going to make the world a very expensive, unhealthy, and inhospitable place to live. I think what we've proved in COVID, I had a conversation with a senior politician in Ottawa who is quite wonderful. He said, our big fear with COVID and the lockdown was that we saw it happen in China, but we thought we could never do that in Canada. And then it turned out all we had to do was ask people. So I think a lot of these really hard things that look intimidating, if someone can explain to you why we're doing this and ask you nicely, Canadians are kind of rule followers. The difficulty is we don't do this in a vacuum, and it depends on much bigger economies than ours. But I think it's in our own self-interest, health and economic, to get ahead of this and start taking action.
And then we actually, before we wrap things up, we actually have one last question pertaining to climate change. The climate crisis, how does it affect the more vulnerable population, and why does it affect the more vulnerable population?
I actually have a slide about that. Can I show you?
Bring it up.
Bring it up. I think I stopped my slides too soon. I forgot that there was one last slide, which is one of my very most favorite. Oh, you need to enable my screen sharing.
Oh, give me 1 second.
And it's about emerging infections, but
Go for it.
Let's see. Let's see if I can even find. Oh, here we go. Okay, so I forgot that I had another slide. Here it is. J.M. Brunkard, who I have no idea who this person is, but was some sort of epidemiologist, entomologist at the U.S. CDC, who studied a disease called dengue, which is a mosquito-borne disease that is probably going to be worsened by climate change, and studied this in Brownsville and Matamoros, which is on the Texas-Mexico border, you know, the border between the US and Mexico. And mosquitoes don't really care if you have a border fence or a border wall or whatever. The mosquitoes are the mosquitoes. They live throughout the city. So risk is actually evenly distributed. And what these folks showed is that economic disadvantage makes all of this worse. So, you know, there's trickle down of risk. And when they look at what's different, the much higher seroprevalence to dengue in the Mexicans than in the Americans. And when they look at what's different between the Mexicans and the Americans, and again, this is relevant to climate change in terms of mitigating, well, where does your water come from? The Texans get it through pipes underground. The Mexicans get it from a tank on the roof that's also a mosquito breeding area. Who's using air conditioning? A lot more Texans than Mexicans are using air conditioning. The Mexicans cool their homes by keeping their windows open. I think there was something here about street drainage and potholes. The Mexicans had a lot more potholes, which are, you know, areas for mosquitoes to breed. So if you looked at what these drivers were, risk should theoretically have been evenly distributed throughout this community. And it wasn't, and it tracked with poverty in ways that you can dig down and figure out. Exactly the same things happened with COVID, right? Where, you know, this is a new disease. It should be equally distributed throughout the city of Toronto. It's hitting hardest in the northwest corner of the city, which is predominantly people of color, predominantly new Canadians, lots more households without English or French as first language, a lot more multi-generational households. So you have people working in nursing homes, people working in meat packing, coming home, it spreads through the household, and so forth. So, you know, you can apply that 1,000-fold to climate change. Do you have air conditioning? Do you have, you know, if the water starts rising, do you have somewhere to escape to, or are you stuck in the low-lying areas and so forth? Are you vulnerable to extreme weather events? Can you afford insurance? All of these vulnerabilities again and again and again, these are health issues, but they're also equity issues. And it applies to climate, it applies to COVID, it applies to vector-borne diseases. Health disparities are very much an issue for us, even here in Canada and even in Israel, I know.
All right. Well, thank you for having that slide. Perfect timing. With that being said, before we get to our closing remarks, I just want to let everybody know that if you missed parts of this event, you'd like to go back and rewatch it or rewatch any of our previous events that we've had online throughout this last couple of months, you can visit the link being sent to you below. It is the youtube.com/user/JNF Canada. Go over there, check out today's events, check out all of our past events. And speaking of events, we do have an event coming up on Monday, which we hope you can join us for. It'll be taking place Monday morning at 11 a.m. Eastern Standard Time. It is a special web series featuring the Israeli Minister of Science and Technology, Izhar Shea. And you can sign up for that event in a link that will be sent to you in just a moment. So with that being said, I'd like to pass the mic over to Galit Levy, the Executive Director of JNF Montreal, for closing remarks. Galit?
Thank you, Phil, for hosting. A special thank you to Dr. Fisman and Dr. Moran-Gilad. You are both really phenomenal. I feel so privileged and grateful that you both agreed to do this for us. You were extremely interesting, and I'm sure we have a flood of questions. We can't take them all, but hopefully, you know, usually some people send us more questions and we're able to funnel them through to you. So well, maybe we'll be able to do that. But really, a huge thank you to both of you. I know you're extremely busy, and especially in this time, and we really appreciate you doing this for JNF Canada. So on behalf of all of us, thank you very much, and definitely join us for our next webinar next week. It'll be very interesting with Minister Shai, who's the new Minister of Science and Technology. We'll again tackle Israel's policy on climate change. What is Israel doing to be at the forefront of this? So it's going to be another interesting part of this web series. And thank you again, Dr. Moran-Gilad and Dr. Fisman. Really, really very tremendously appreciated.
Thank you so much for doing this.
Thank you. My pleasure.
Thank you so much. Very interesting. Hi, everybody.
We hope everyone enjoyed. Have a great afternoon, and we'll hopefully see you all on Monday. Take care till then.
Bye.
Cheers. Thank you. Bye-bye.
Bye-bye.